My name is Björg Pálsdóttir. I'm the CEO of the Training for Health Equity Network, but also a board member of the Network Towards Unity for Health. And thank you so much for joining us on this important topic. And just to let you know, first of all, that this session is being recorded and can be reviewed later on. And if you have comments or questions that when you're listening to the expert, please submit them in the chat box. And we'll do our best to get the questions, answers, and included in that conversation. So as you see, the topic is social accountability, both focusing on implementation and research. And I just wanted to give you a quick overview of the Training for Health Equity Network. Some of you know it. We've been a member of the Network Towards Unity Health for a while, and we've been around for the last 10 years. So if I could ask you, Nick, just to go next with the next slide. So what we are is a growing community of practice of schools of health sciences and medicine that are officially or sort of have the mandate of social accountability or at the leadership level. We've got 12 medical schools, and now we've got several other research partners. And health equity is at the core of what we do. There are several key strategies. If we could just go to the next, and here's the school. These were the founding schools. They are located in very different settings and different health systems, but what was very interesting when we got established and when we met together was that we actually discovered that they shared some common strategies. So next. And the sort of process that they go through, that these schools go through, and that is at the core of social accountability, is that you actually align your education, research, and service to what's meeting the needs of all the communities that you serve. And that this is done in partnership with stakeholders, including those most vulnerable communities or those that are least served. And this is something that's an iterative process. You then design your teaching, learning, research, and service to address those needs. And some other strategies you'll see later that are aligned with social accountability. And the goal is, of course, is to train a fit-for-purpose health workforce that serves all of a country's or region's populations, and to improve both health equity and health outcomes. Sometimes people talk about or understand social accountability as mostly focusing on equity, but it's about quality for everyone. Quality is just as important as equity. And all of this is also, I think, what's unique about social accountability is that there's a real focus on health system strengthening and a much more sort of interdisciplinary approach, if you will. Next. And these are the common strategies. I'm not going to read them through, but it really starts with the needs at the core, and that's where the starting point is. And there's a really focus, all of our schools and those that are striving towards social accountability have targeted recruitment strategies. That is, they are recruiting for retention. They're recruiting to make sure that there's enough health workers that decide to work in underserved communities. And most of them, often those strategies involve recruiting from these communities themselves. And the curriculum integrates not only, it integrates both social and basic clinical and population sciences. And social determinants of health are important for students to learn that go through schools that are socially accountable. And look, I think I want to get as quickly as possible to our panelists, so I think we could go to the next slide. One of the first tasks that when these schools were brought together, what we decided to do to make sure to look at both, because there was shared strategies, but also to look at at the core of social accountability is actually knowing whether you're meeting those needs. So our first common task was to develop an evaluation framework. And so this is sort of the general points of that were brought up based on successful experiences of the NET's member school. And it should be said that all of these schools have successfully, compared to other schools, more traditional schools, have graduates more, who are more graduates that work in underserved region, and Sarah will talk about our study as well. But at the core components of the evaluation framework is starting to look at the needs of the health system, needs of students, and needs of communities, and particularly the most vulnerable. And then a second element is not only about educational strategies, it's also about how do we work with others. It's about actual, true, authentic partnership. Not just that we have a community member on the board, but part of the framework was getting the schools to look at, well, is their voice heard? How are they represented? Where do we put our resources? Are we actually putting the money where our mouth is? Are we actually investing in training that takes place in the community level, not just in hospital settings? And then you have the question as of where, who you teach, who are the students, but also who are the faculty, as well as what the content of the curriculum is. Is it aligned with the needs that we identified? Is our research focusing on some of the priority areas? Is it also looking at strengthening health systems? And then again, really looking at how are we actually contributing to improving health service delivery, both the equity, but also the quality. And then again, what is the difference that we're making? Where are the graduates? What are they doing? Have we actually had an impact on health service delivery and the health of the population we serve? And is our research not only published, but it's actually affecting policies? Is policy being changed because of the research that we have produced? Are we sharing these ideas with others? Are we working in partnership to actually improve health in our region and beyond? So I guess next, which brings me to the next presentation. So we're going to have questions at the end so you feel free to put it into the chat box. But this is just, I wanted to introduce you to the NET, and the framework that I just presented is actually at the core, at the basis of the research that we've done and some of the work that's going to be presented really briefly. We're not doing it justice, but it's just to sort of, so that you can hear the different types of work that's being done at socially accountable schools. And that is all based on this broader framework that the full framework has indicators and resources, etc., and is available on our website. However, let me just get quickly to introduce John Hogenbirk, who is a member of our evidence group and works at Northern Ontario School of Medicine. And can I just hand over to you, John?
Yes, well, good morning, good afternoon, good evening, and welcome to everyone. It's a great pleasure to come in here and join just for a few minutes and talk about the program here at the Northern Ontario School of Medicine here in Canada. I'm going to touch upon two of the things that Björg talked about. One at the beginning, the admissions component, and then some of the practice outcome components where individuals are practicing. And so my presentation will just touch lightly on two of those items. Next slide, please. There's lots of people to thank and just a few people to blame. Next slide, please. So I just want to refamiliarize you, or if you're not, if you're seeing this for the first time, to understand where NOSM is. We're in Ontario. We're in the northern part of Ontario, which is in the upper 2/3 of this map that you see here of the province. Northern Ontario is about the size of France. They give you a size indication of the size. And the campus is distributed over 90 communities that vary in size from about 150, 160,000 people to communities as small as 5,000 people, sometimes even less for some of the remote and Indigenous First Nation communities where you might get a couple hundred people. And if you look at that screen, you'll see the yellow line there is essentially the extent of the road network. Above that, there are no roads. Well, there are ice roads, but that's the extent of the road network. And so towards the south of that is, of course, when you have a greater density of road. And the more south you go, the more dense it becomes. Next slide, please. So we've been doing studies on social accountability and how that has been implemented at the school here since 2005, which is when NOSM began with its charter class. And I want to focus on just two parts. One is the studies on medical school admissions. And the question that we're trying to answer here is, has NOSM been successful in selecting students who are representative of the population of Northern Ontario? So that's a big social accountability goal, is to try to get your doctor population to resemble or represent the larger population of the service region. And the second study I'll talk about is a tracking study of all medical learners. We start when they begin their undergraduate, we follow them through their postgraduate studies, residency training, and into practice. And the main question we have is, are they staying to practice in Northern Ontario? Next slide, please. So very quickly, for the admission study, we looked at the first 10 years. And there are 4 target areas that I'll talk about. Northern, you'll see them highlighted there: Northern, Francophone, Indigenous, and rural. So for Northern and Francophone, students with Northern and Francophone backgrounds, rather, we pretty much achieved, NOSM has pretty much achieved the goals that they set out for themselves. They're representative of the population of Northern Ontario. The Indigenous representation was a little bit lower. It's better than any other medical school in Canada, which is the average there for all Canada is about 1%. At 7%, it's clearly better than the national average, but it's lower than the target area of 12%. Now, the good news is that NOSM implemented changes to its admission criteria, and since 2016, so for the subsequent 3 years, has actually managed to achieve representation of Indigenous students in its student population. And the last one that I'll talk about is students from rural areas. So the goal is about, I should say 44%, not 4% there. We're a little bit below, so it's a small problem, if you like, a small problem from small areas. So we're pretty close, but the NOSM's not close enough. Next slide, please. And this one slide with 2 bullet points summarizes a whole extensive series of studies, some of which are published and other ones are in progress right now. But basically, for family physicians who have completed their undergraduate and postgraduate, so their residency training at NOSM, over 90% of them practice in Northern Ontario, which is pretty darn good. So they are staying and they are practicing in Northern Ontario. For specialists, the rate's at 28%, and in part because Northern Ontario only has 2 major cities. One is Sudbury, which is about 160,000 people, and the other one is Thunder Bay, which is about 120, 30,000, depending on who you count and what you count. So these are not large areas. So it's actually quite good and reasonable, I think, that roughly 28% are staying there. There's room for improvement. They're not all in the smaller areas. Many of them are still gravitating to the urban areas of Northern Ontario, which is still quite small relative to other parts of the country, but they're not in all the areas just quite yet. So there's still a bit of a challenge ahead for us. Next slide, please. So summarizing very quickly, NOSM does select medical students representative for a large part, they are representative of the population of Northern Ontario. And NOSM is producing physicians who stay in Northern Ontario. And these are 2 of the main social accountability goals. There are others, but these are kind of the beginning and sort of the end of that time frame, if you like. And it's not to say that there are no challenges. They're ongoing, but it's clear right now that NOSM is achieving some of these key mandates, some of these key outcomes associated with social accountability mandate. Next slide, please. There's some selected publications. I'll put up a web link later on, and these publications are linked there. But also, if you're interested in more information, I would ask you to, or suggest that you check out our Focus on Research in Focus newspaper series or news bulletin series. These are 4-page reader-friendly newspaper or news bulletins that you can access online. Next slide, please. There's a web link at the very bottom. And thank you for your attention.
Thanks so much, John. So again, please, you can feel free to start typing in your questions in the chat box for John, and then we'll take the questions at the end. So next panelist is Dr. Sarah Larkins from James Cook University. And she's also the director of Health System Research Center there. And I will hand over to you.
Thanks, Björg and John. Yes, look, welcome everyone. I'm speaking to you tonight from Wulgurukaba and Bindal country. That's the First Nations owners of the country where we're on here. I'm from James Cook University. We're a relatively new School of Medicine and Dentistry. We took our first students in the year 2000, and we're set up with an explicit focus to train a health workforce fit for purpose to meet the needs of rural, remote, Indigenous and tropical populations in our region. So you know, that's been our mission from the very beginning. Next, thanks, Nick. So we know that doctors that train in rural areas are more likely to remain in practice in these communities, and we've got like John and Nossam, we've been tracking our students and graduates from the beginning, and found that JCU is actually Australia's most successful university in producing health professionals that stay in rural and regional careers. So I won't go through the numbers, but we've published a few papers for people who are interested in that. Next, thanks, Nick. So I'm not here to talk about JCU's graduate outcomes. I'm here to talk about the NET graduate outcome study. So Björg introduced the NET Common Evaluation Framework, and one of the things that the NET partner schools wanted to do is hold ourselves accountable for whether we were doing what we said we wanted to do, and see how well we were actually doing that. So as you can see, this work from the evidence group is very much a partnership effort. It's a Training for Health Equity Network project. It's led and coordinated, I guess, out of James Cook University, but we have 8 schools from 6 countries around the world in Africa, Australia, the Philippines, 2 schools in the Philippines, and Belgium, all contributing, and Canada, all contributing data to this study. So big thanks to the co-authors. Next, thanks, Nick. So you've seen the evaluation framework. The graduate outcome study was designed particularly to address 2 components of that framework. So the first is, who are our learners? Who do we teach? And to really understand how representative they are of the populations we serve. And the second is, where are our graduates and what are they doing? To really see whether we were being successful in our mission to create fit for purpose health workforce. Next, thanks, Nick. So we have been set up this graduate outcome study and adapted a standardized questionnaire that's used at entry and at exit from the medical program in consistent form at all these very varied medical schools. So there are minor adaptations. We classify disadvantaged populations along 3 dimensions: a dimension of geographic disadvantage. So each country comes up with 5 levels of geographic disadvantage, a dimension of socioeconomic disadvantage based on quintiles of family socioeconomic income, and a dimension of sociocultural disadvantage based on coming from a minority group. And this is, the intention is to build up a prospective longitudinal cohort from these students, so at entry, at exit, and then 1 year, 4 years, 7 years, and 10 years post-graduation from the medical program. So an ambitious project which takes some time to build up. However, it's of substantial size now. We now have 5,200 learners enrolled in our super database from all those schools. So it's quite a big a big and useful resource, and we're starting to build up some of those learners who we have entry and exit data and moving into the postgraduate follow-up. So I'm going to just very briefly present some data about entry and exit cohorts as separate cohorts. And firstly talk about practice intentions and intention to practice in rural location using some adjusted odds ratios. And this is from work that was published late last year in BMC Medical Education. There was an earlier paper in Medical Education Journal showing that the makeup of students in the DNET schools from the entry survey was very, very different to that in most medical programs. So far higher proportions from low socioeconomic groups, from rural and remote backgrounds, and from minority groups. And they had higher intentions to practice in rural and other underserved areas. So let's look at intention to practice in rural location. Next, Nick. So we found, as you might expect, that those from a rural background were considerably more likely to intend to practice in a rural location. Next, thanks. Similarly, those from a low income background were almost twice as likely, 1.8 times as likely to intend to practice in a rural location. Next. Those from an entirely regionally based medical school without a big city campus were 2.2 times as likely to intend to practice in a rural location. Next. And the underserved socio-cultural group at entry showed a positive intention towards rural practice location, but this wasn't significant once we did an adjusted analysis. Next. We did find that the intention to practice rurally across all these schools, and this was based on about 3,500 learners, did drop a little bit from entry to exit. However, the intention to practice with underserved populations didn't drop at all in that time. So there's still a little bit of work to do in terms of the, perhaps the hidden curriculum that might be going on in some school environments. Next, thanks, Nick. So the other thing we looked at was intention to work abroad. Sorry, plane is flying overhead. And we did look at this for all schools combined, and found that those students from an urban background were much more likely, 1.4 times as likely, to intend to practice abroad. And those with the top 2 quintiles of family socioeconomic status were much more likely to intend to work abroad. And we did an analysis particularly looking at the 4 schools from Africa and the Philippines, for whom medical immigration is a major issue in terms of retaining health professionals to work with underserved populations, and found that the intention to work abroad or to emigrate dropped significantly from entry to exit. So that was encouraging. These schools are doing something significant to socialise people towards meeting underserved populations' needs. Next one, Nick, thanks. And lastly, we also looked at intended practice discipline. So the grey bars are the students at entry, and the orange bars are students at exit. Next, Nick. And what the 2 things to look at are, firstly, a great growth in intention to work in family medicine or general practice between entry and exit, and click again, and a very dramatic decrease in intention to practice in surgery from entry to exit. So again, the things they're experiencing, the communities the students are visiting, and the needs they're seeing are having some influence on intended discipline. So that's all I'm going to say. That there's a lot more about this published. We're going on to do more publications. A lot more work to do, obviously, to follow up this group of students and see whether intentions, how intentions transfer into actual practice locations and fields of practice. But it's an interesting process. So thanks. I'm going to hand back to Björg and Monsie.
Thank you, Sarah. Just moving on quickly to Dr. Monserrat Guingona from our Ateneo de Zamboanga in the Philippines. I won't make the introduction longer because I want to get going. So go ahead, Monsie.
Yeah, hi everyone. So I'll be sharing how social accountability strategies are being implemented in socially accountable health professional education, or SAPIS schools in the Philippines, and how we have been measuring them. So next. I would like to actually acknowledge the authors of this multi-institutional study. The Philippine Impact Study was actually conducted in 2 SAPIS schools in the Philippines, UP Manila School of Health Sciences in Palo Leyte, as well as ADSU, or Ateneo de Zamboanga University School of Medicine. And for the purpose of this presentation, I will just be presenting the results of ADSU-SOM, the university where I'm coming from. Next. So to give you a bit of a background, 25 years ago, Western Mindanao region, home to the Ateneo de Zamboanga School of Medicine, had the Philippines' 14th poorest municipalities, with around 2 provinces ranked first and second in malnutrition and hunger. Also, the infant mortality rate then was at 75 per 1,000 live births. And to top it up, there were 80% of the towns in the region were doctorless, with no basic health services. So to address this, ADSU-SOM was established with a mission to help provide solutions to the health problems of the people and the community it serves. So it adopted a strong focus on social accountability that used various strategies. So next. One, it's its curriculum with a strong social accountability mandate. So it's community-engaged medical education curriculum, wherein the region's top causes of mortality and morbidity became the core content of the curriculum, and the needs of the community became the fundamental part of setting the medical school's education and research, as well as community development mission. So because of the longitudinal community immersion, students spend about 50% of their curriculum time in the communities, and they actually actively engage with them, promoting public health through activities and research. So to document all these evidences, next. To document the evidences from all these strategies, a study in collaboration with the NET was then conducted that involved both local and international partners to provide both content validity as well as methodological and statistical direction. Also, a mixed method approach was used to evaluate all the range and all the complexities of all the health impacts that we were getting. Also, it was ensured that data were really collected from the stakeholders, and ultimately that the research involved a counterfactual or a non-SAPE graduate and non-SAPE communities which serve as our comparator. So next. Since the research was a multi-institutional collaboration, a conceptual framework, as you can see, was developed to serve just as a guide to help the researchers know where their individual papers or researches fit in the entire evaluation framework. So overall, the study looked into health workforce outcomes and community outcomes. So first, for the Philippine health workforce outcome, next please. We wanted to describe the difference between graduates of SAPIS schools compared to graduates of non-SAPIS schools in the same region in terms of their motivation towards community-based service and their training in population health. And results actually showed that ADSU-SOM graduates were more likely to be motivated to join their medical school because of their desire to help others, were more likely to intend to pursue family medicine, work in rural health units, work as government hospital generalists, as well as were more likely to report positive attitudes to community service and health equity. Next. Furthermore, practice locations were also compared. So, and the results showed that significantly higher graduates of ADSU-SOM were practicing in communities with a population of less than 100,000. They were also practicing in their home country and region, as well as majority of them, or significantly higher graduates, were practicing in lower income community or category, communities with low income category. So next. Also, to determine community outcomes, which we think is important, a study was conducted among recent and expectant mothers to determine how well the students and the graduates of SAPIS schools strengthen the health system, provide equitable services, and transfer knowledge, attitude, and behaviors on child and maternal health. So it was actually found out that mothers in SAPIS-served communities were more likely to have reported that a health professional actually discussed with them blood and urine results, that they have received prenatal checkup before the 4th month of gestation, that their youngest child received vitamin K soon after birth, and that they had full immunizations, and that their child were less likely to be of low birth weight, and ultimately that breast milk was given to the youngest child up to 6 months of age. So all in all, these study results provide evidence that SAPIS schools improve health equity and coverage, increase health workforce recruitment and retention, as well as strengthen local health services. Next. So over the period of 25 years, Western Mindanao's region's infant mortality rate has now decreased to 5.5 to 7 per 1,000 live births. Also, there has been a 55% increase in the number of municipalities now with doctors. And to date, ADSUSOM has produced 425 board-certified graduates, and 243 of them have completed an MPH degree. 96% are in the Philippines, 63% practice in the region, 39% in rural and remote areas, and about 11% actually practice in armed and conflict areas. So since evidences of the effectiveness of SAPIS schools have now been documented, our next step is actually to monetize all these outcomes through a social return on investment study. So we actually believe that this is vital, since it's not just for the purpose of just being able to tell people that the benefits of a SAPIS school outweigh its costs, but ultimately we want to get more community partners involved.
Thank you so much, Monsie. As I say, I know the time doesn't give justice to all these fantastic studies that are being presented, but it's just to give you a flavor. And I see there's some questions coming up, but I want to hand over quickly to Dr. Robyn Preston, who was a member of JCU, but now has moved. But go ahead, and then we'll go to the questions. Go ahead, Robyn.
Yeah, thanks, Björg. And I am still in Townsville in beautiful Wulgurukbar and Bindal country. So what I wanted to present now is perhaps a little bit different. And I think some of you are probably sitting here thinking, well, that's all great, but why are these schools so different? What was it about them that all made them want to be socially accountable? And probably more importantly, how can I make changes at my school to enact some of these changes? So I'm just reporting here about my PhD research, which I did a few years ago now. And that's what I was interested in. I saw from the net that there was all these different schools, and I wanted to know what were the contextual factors or the external and internal conditions that type of influence them to be socially accountable. And you could see here that the 4 schools that we've heard a little bit about. And I did this through case study research, so that helped me really answer that wicked problem. I interviewed different people, so I interviewed people from Australian health policy experts over the phone. I interviewed GPs in South Australia in their cars, and Filipino rice farmers at local health stations. So there was quite a diverse group of voices, and I was interested in why they thought their medical school embraced social accountability. Next slide, please. So what I found, so everything's out of whack here a bit, and I'll just get you to click a bit, Nick, because there are some great quotes here. But what I want you to really think about, this was built from analysing these data by talking to these different stakeholders, and I found that there were different internal and external factors influencing these medical schools. And I found that these became the building blocks necessary to assist the movement to social accountability. So we all can probably know about the demands of workforce. You've heard from these different schools, led to innovative educational programs, and that was established with or without government supports. But it was also really what was the foundation I found, and what I think we should all be thinking about was leaders and champions. And these people started often with nothing. At Monsie's school, they started with $500 and a few friends. So what I think we still have to continue to think about and move forward with social accountability is that leaders and champions had this type of fire in the belly, of like controlled rage to change things, because it really took an effort at these schools to change things, and they didn't rest on their laurels, but they continued to push alternatives. It might sound surprising now when social accountability is the flavour of the month, the World Health Organization is talking about it, but schools really spoke about how they were ridiculed. And when they were facing those dominant paradigms and posed alternatives, they were faced with ridicule. You can't have students from rural areas, even JCU in Townsville, you can't have a school outside a capital city. But the leaders were really important, and leaders could come from the community as well as from students. So if you're at a school that perhaps isn't embracing social accountability, I want you to keep this in mind and look back at the history of what Dr. Chris did at ADZU and how the community fought in NOSM for their school. Because these people had that political nuance and connections, not only at that higher political level, but at the community level. In the Philippines, the local government are really important and at that community level and speaking with people as well. And students are influencing a lot at the international as well. The other challenge I want to put forward in this short presentation is for the net schools, and for schools perhaps that have got that stamp saying that they are socially accountable. I think there's a real danger that we just rest on these laurels and not continue to look to challenges and look at the differences. So are we looking at things such as gender differences? Are we looking at different issues around climate change and embracing these changes and moving forward? I think that people have to keep fighting and looking for those alternative models, and also to be critically reflective of our own practice. Are we really embracing community leaders and students' voices, or are we continuing to think about how things were 15, 20 years ago? So leaders have to be quite, as I said, quite skilled to work both with community level people and understand that leadership and take a strengths-based approach from communities, but also have that political knowledge to link in at different levels of government as well. Next slide, please. So there are a couple of papers around this, but I really thought that would be interested in any questions from people, and I'm sure the panel can answer as well, as what do we think the future is for social accountability, and perhaps embracing what leadership might look like there as well. So thank you.
Thank you so much, Robyn. I know some of the questions are coming up and some of them are being answered, but I think all our speakers, and not least Robyn, has raised some questions, because there's now sort of on paper, if you will, at WHO, standards and commitment to social accountability. But we think it's really important to really look at, well, how do you put that into action? It's not easy, it's not straightforward, but at the core of it is actually continuously asking ourselves what's working, what's not, doing research that's focusing on that as well. So opening up the floor to any questions. If there are people that feel that their question hasn't been answered, that's so far in the chat at the moment. I know there's, as you've seen, there was some question about what are the criteria, selection strategies, and they actually depend on the school. Context is hugely important, and that's when we were doing our evaluation framework, we were trying to identify things that could be compared, but allow for enough flexibility so that it could be aligned with the context. And I think that's very important. So any particular question at this point?
Okay, can you hear me?
Yes.
Okay, I'm probably the oldest person in the room at the moment, and I have been involved in 5 of the medical schools as part of the network, and now some in the net. Very strong influences towards social accountability were, in some cases, government policy definition. That was so in Nigeria. They wanted a primary care-led program, we set up one based on living in villages. And I've met those graduates 30 to 40 years later. They are all absolutely sure that that experience turned them to a much wider view of the social implications of medicine and their role. Yeah. We used to have thrown at our heads, oh, you're just training barefoot doctors. I've worked a lot with Lagos, the top teaching hospital in Nigeria. They say the best interns, many of them come from that medical school. So you just stare down the people that want to mock the principle and keep going. Now in England, now there are 5 new medical schools being set up all in a rush to get ready for the lack of European doctors in Brexit, and we won't go off into that one. We set up a school in Durham up there, and our community placement in an industrial area was in the welfare sector. And then, if you want to see the reality of the world of social deterioration, suffering, despair, go to the welfare sector. Get out of the health boundary and go there. And several of those graduates have settled right in the middle of the area of the Northeast, which has the worst indices, the worst social things. And if you talk to people, you always get from the experience in the community or the welfare, what I've now learned to call a transformative experience. We knew all that 30, 40 years ago, but every 10 years, a new term comes up and you get PhDs for it and that sort of thing. I've never done a PhD. I've been too busy setting up medical schools. I'm not an expert, but there it is. So that transformation puts the drive and the commitment into the minds and the hearts of the graduates. And that's because the welfare sector remains relatively invisible to our studies. I think we may be missing an opportunity of both a study and a placement for those transformative learning experiences. Okay. It's not exactly a question, but...
Yeah, thanks so much, John. It's Robyn here, and I found from when I did my lit review that actually it has, social accountability was around, it was actually really post-colonial Africa where it came out in those African schools. I think you could trace it back to there, those when they needed to train their own doctors there. So it's really interesting to hear that history, and I think I agree also that government policy is essential, and lobbying, the rural workforce movement in Australia is one case in point that was brought up by both Flinders and JCU as being essential for their establishment as well. So thank you for that.
Yeah, you have to actually also try and actually be part of that advisory persuasive mechanism. I was able to do that by chairing the Rural Undergraduate Steering Committee in Australia for the Commonwealth, and also, rather oddly, because I'd only just arrived, chaired the Accreditation Committee. And we formally put into those guidelines community orientation and so on. And Sarah Larkins' dad took over from me and did the job for the next 5 years and did a very good job.
I think you raise an important point, John, about about harnessing the experience that the students have, and that's something that we've been working with all the schools, because we couldn't do justice here, but all of these schools that are doing things have very interesting stories of the experiences that their students have in a wide variety of community settings, well beyond health. And so the next thing that we really want to do is to understand those experiences and the impact they have on the students and the graduates and subsequent career paths. And the other point that you raise is we're actually assessing our impact, or attempting to assess and record our impact in terms of policy impact and the extent to which we've been able to share our ideas and influence others, including policymakers, to make more equity promoting health policy, I guess. Mm.
Yes, I think the Net has done a very good job in getting a committed group running and organized. I think JCU, its best thing was to be disengaged from the large University of Queensland at the beginning. Another of my tasks was to chair the review of the Townsville School for the University of Queensland. And they were struggling because Queensland refused to take very seriously the fact that you could learn medicine out in the rural area. And it was an implied recommendation that they needed to be let loose from that tethering of Queensland and build on their own momentum.
True. That there are lots of questions in the online, in the chat too, coming up here. There's a question, I wonder what panelists' thoughts are on applying the idea of social accountability in other settings outside of medical schools, such as hospitals or in clinical practices. Monsie, or did you want to comment on that from the Philippines point of view? Or?
Yeah, so hi, yes, thanks for the question. I think it's really important. Social accountability shouldn't just be in medical schools. Actually, the health system actually is played by professionals from not just medicine, but nursing, midwifery, and all. And I think social accountability principles should also be spread out to all these professionals who play a part in the health system. So in the Philippines, they're trying already to introduce community immersions among the specialist program. So when you enter the residency program, at your final year, they ask you to pay back, at least return your services to the community. However, it's just it just holds true for the government hospitals, but not yet for our private hospitals. But I think, yes, it's really important that social accountability principles are spread all through the other professions as well.
Can I comment? It's Maureen McClelland from Sudbury up at Northern Ontario, part of NOSM's academic network. And we have adopted as one of our 5 key goals out of our recent strategic planning engagement, the goal to be more socially accountable. So this is influential in terms of the med school's influence during our engagement process. And it's really struck a chord with our other professionals who feel that at times we've left marginalized people on the margins, and they're looking for, it's resounded with them quite well in terms of it's why we got into healthcare in the beginning. And so many of our other professional staff outside of the medical staff who've already been quite socialized to this because of NOSM are really latching on. And just, you know, as a really poignant example, it's Pride Week here in Canada, where we have reached out to the community and invited them in to co-design and co-deliver programs and services that would meet the needs of our LGBTQ two-spirited individuals that we serve, but don't serve as well as they'd like to be served. And so, you know, in addition to the Indigenous outreach that we're doing, there are other communities that we have reached out to and invited in to co-design and co-deliver services.
Björg, thank you, Maureen. I just wanted to add, there's a question there, well, beyond medical school and even beyond health profession, to look at social determinants of health. And our newest member is actually the University of Texas in El Paso. And it is actually the university that has the social accountability mandate. We were incredibly impressed by, it didn't matter whether it was the basic science department, dentistry, engineering, they all had that social accountability approach. So that more than 50% of all the graduates of the university actually are first generation. First of all, the 80% of the population in the university are of Latino descent or are Mexican, because this El Paso is a border city. And they've actually, 50% of them are first generation college graduates. And again, it just shows the importance of understanding and doing research. And one of the things that they have bring as a strength to our network is they've been really looking at what happens, because a lot of people that come from a poor economic background, and often women, they have other responsibilities such as children or extended family. So they've looked at options. How can you support students that are going through this process with short-term loans, looking at, so the university leadership has influenced bus routes in order to support folks. So this is really something that ideally should go beyond medicine, because it's about, you know, society as a whole. So it is happening. So I just wanted to share that. There's also some questions earlier on around the issue of when, I'm assuming to a great extent, richer countries are recruiting doctors from poor communities into their underserved communities. What are our panelists' thought on that? Anybody want to take a stab at that? How do we, I mean, there's obviously, you know, a WHO ethical contract, I'm blanking on the exact name, where you're not supposed to do that, but folks do, and it's important to reflect on it.
But I mean, in the Australian situation, we've got a terrible record of poaching doctors from countries that can scarce afford to lose them, and then not only that, putting them in underserved areas in some of the hardest jobs in the country, and providing very little support to help them survive and thrive. So there's increasing recognition that we have a responsibility to train enough doctors to meet our own needs in those underserved areas. I was challenged, because I've always held that view very strongly myself. I was challenged at a meeting in the Philippines with a number of doctors also highlighting the important role of individual choice. So, you know, balancing those two things is important, so that people have choice, but if they can be exposed to an environment that inspires them to stay and serve in their own country where the needs are that much greater again, then so much the better. But you know, I must say that there are two sides to every story, and we have to think about it in a broad way. And I think there was actually a late modification. Monsie can correct me. I'm sure you're more across it, but of the statement on the international migration of doctors that added a few clauses to that effect.
And I just want to encourage, because I know that I know some of the folks that are on here, so feel free to respond. I think this is you know, we know this is a challenge, and none of this is straightforward. So anybody with experience or thoughts on the question here, feel free to jump in. So I see there's a question from Lori also regarding mental health for staff, students, and communities. That is certainly something. Anybody want to take a stab at that?
Maybe if I could just clarify, it's emerged as a critical area of concern at UCT, I guess partly in response to the fees must fall movement, but partly in relation to the kind of structural violence. So the way in which universities have been structured in a way that supports a particular kind of student who is well resourced, who has come from a particular background, a particular kind of school, and the more subtle forms of racism and sexism that make it very difficult for people to integrate or to express themselves. So there's been concerns around suicidality amongst both staff and students, and obviously concerns around depression and mental health services more broadly, particularly for people living on the periphery or living in poverty. And just thinking that's when we're talking about social accountability, that is a core thread that is often invisible, and the notion that the personal is political. So I was just wondering to what extent that's explicit in the framework and the work that the network is doing.
Well, I mean, Laurie, I would answer that. I mean, I think each every institution that decides to sort of evaluate how things are going against the framework has to really customize and decide what their context and what their issues are. So when I speak about, for example, a JCU experience, we've found that we're doing quite well at attracting Aboriginal and Torres Strait Islander students into our course, but not so well at supporting them all the way through, you know, implying that there are, you know, a whole lot of these reasons, whether it's sort of structural racism, whether it's disadvantage, poverty, family issues, a whole lot of issues. So that the process of examining those outcomes and looking at how we're going and critically reflecting on that leads us to then do more study to find out what actually is going on and how best we can address those needs to even out those inequities. So you know, it's certainly never been designed, and there's a lot of people here that were involved in the co-design of this framework, but the intention was always not oh, let's tick and flick and yes, we're socially accountable, woohoo. It was very much, let's critically reflect on what we are intending to do, what we're trying to achieve, how well we're going against all these things, and where we can improve. And sort of the day you stop trying to improve and the day you stop trying to do things better, you know, it's the day that you know you're not socially accountable, I reckon. You've got to keep holding yourself accountable and trying to make things better.
Thank you, Sarah.
That's the intent. Mm.
So, as always, you know, this is a complex topic with so many elements. So, and an hour is a very short time to even begin to scratch the surface. So, hopefully this is just the beginning of the conversation, but I think it is an important one, and that's why the network and the net are important communities of practice for all of us struggling with these issues, and important way to share our resources and findings so we can kind of help each other in this effort. And that, I think, is both the goal of the network and certainly the net. So again, just want to summarize, and then I want to hand it over to Nick Torres from the network to sort of conclude. But thank you so much for attending at late and early, wherever you are. And I hope this is just the beginning of a conversation and sort of sharing of your research. So if you have research that fits into this, you know, this is going to be something that we do by sort of building the case for. That's why we're also involved in policy advocacy. But I think ultimately the real challenge is on the ground. It's this sort of messy, hard stuff of dealing with really entrenched and deep-rooted problems. So let's continue the conversation. And thank you, Nick, and the network for allowing us an opportunity to share our work. I'll hand over to you.
So I want to just thank everybody for joining us on this effort. I think the network's role within this is we want to help create that movement of moving, you know, the actors towards social accountability standards and implementation. And part of it is taking the lead or taking the lessons learned from the leading institutions. So this symposium was fantastic. I think it was missing in our repertoire of knowledge in terms of how do you actually do that. So thank you for everybody doing that. You know, part of what this is our sort of theory in terms of how we'll do that. And it starts with sharing and inspiring other people to do it. So again, this symposium did that and provided some tools. One thing that Robyn had said is, you know, oftentimes people don't move to local action because they don't understand the process of system and policy change. So we're hoping that the network can actually provide some of those tools and talk about what does that process look like. But ultimately, you know, when we look at it is, you know, we want to help move towards local actors. And so that's through policy and system change for local actors to have the tools to actually do it within their own countries or their own regions or their own institutions. So that's simply sort of how we're going to do this. This symposium will be shared. We'll share it and hopefully promote it and then hopefully feedback for I think the 12 institutions that are leading to the net. Hopefully you guys will continue leading and we'll continue sending people your way so you can help other institutions take the same, do the same as you have done. So with that, I would just say thank you, Björg. And so thank you everyone for joining us, and we will distribute this once it's published.
Okay, goodbye all.
Thank you.
Thank you, everyone.
Thank you, everyone.